Welcome to AETCM, the Emergency Medicine Channel. Shall I start, sir? Presenting the case of a 50-year-old female who came to ER with complaints of pain and localized swelling along the left radiocephalic AV fistula site since one day, and she also complains of fever since one day. And on initial 10-second assessment, the patient was conscious oriented. She was able to talk in full complete sentences. And on ABC, the airway was patent. There was no pooling of any secretion or gurgling sounds was tried. Breathing wise, the saturation was 95% in room air, and there was presence of on auscultation bilateral basal Krebs was present, and respiratory rate of 20 per minute. And on circulation, the patient had a heart rate of 86 per minute with a BP of 160/110 millimeters of mercury and a capillary refill time of 2 seconds. And disability wise, the GCS was full 15/15, and the pupils were equal and reactive of 2 millimeters. And GRBS was 108 milligram per deciliter. And exposure, the temperature was 100 degree Fahrenheit. So there was no presence of any rashes all over the body. The external swelling was present along the left radiocephalic fistula site.
Left radiocephalic fistula site.
Yeah.
All right. How long has the swelling been there?
It has been there since last 2 days.
2 days.
Yeah.
Okay.
And following which we had patient had a temperature, so we initially had given her injection paracetamol, 1 gram IV stat. Following which we again reassessed the temperature. Temperature had gone down to 99.
All right. So did we run any point of care?
Yeah. We had done an adjunct to the primary survey, and we had taken only CBC-CRP point of care was taken, showing a total count of 15,000 with a HB of 7.8, platelet of 178,000, and CRP of 72.6.
Okay.
So we also did a venous blood gas, showing a metabolic acidosis with a pH of 7.33.
All right.
And a bicarb of 16, creat of 9.2, and potassium of 4.
Okay.
And we also done a chest X-ray associate. It was normal.
All right.
Yeah. And then we went on to take the sample history. Sample history, the patient was a 50-year-old female. She was a known case of type 2 diabetes, hypertension, and CKD stage 5. She was on 2/7 dialysis. And that day was the due dialysis day.
All right.
So last dialysis was done 3 days back. And she now complains of pain and localized swelling along the left radiocephalic fistula site since last 2 days, and also fever since last 1 day.
Okay.
So there is no history of any cough or breathlessness or abdominal pain, body ache associated. There is no history of any trauma to the left hand, and there is no history of any weakness of left hand or paresthesia or numbness along the left hand.
All right.
Then we asked about her allergic history. There was no presence of any allergy to any drugs. And medication history, she was on Lasix and also on 40 mg BD, and on glimepiride 1 mg, metformin 500 mg, and also on Arkemin 100 microgram, and on Nicardia 20 mg also. And her past history includes CKD stage 5, type 2 diabetes, and hypertension. Her last meal was taken 6 hours back. And initially itself, considering the infection along the fistula site, we are suspecting an infection, a local infection along the fistula site. We started on an empirical antibiotic. So empirical antibiotic, initially we started on injection augmentin. That's amoxicillin clavulanic acid, 1.2 gram. IV stat dose was given after test dose, and after that we had also arranged for 2 pint PRBCs.
Okay.
And also then following which we had given an expert consultation for nephrology and vascular surgery. And also we had along with that we had also done a Doppler of the AV fistula site to look for the AV fistula patency or presence of any thrombus is there, or any localized collection along the subcutaneous tissue. And before that, we had done also the local examination. On local examination of the left hand, there was a presence of swelling on the local site of around on the AV fistula site of around 2 into 2 centimeter, and it was around that suture site area of the AV fistula.
Okay.
And there was presence of local rise of temperature and also tenderness along that site.
All right. Okay.
And the left radial pulse was palpable.
Okay.
There was no presence of any like loss of sensation along the site, and the power of was 5/5 of all upper limb hand muscle. The hand muscles was normal, and there was no pain during passive stretch.
Okay. So basically the AV fistula was patent.
AV fistula was patent.
Bruit.
Yeah, bruit also.
Thrills were heard.
Yeah, so present.
All right. So you're suspecting a superficial infection.
Infection, yes.
All right. So you did a local ultrasound for the same.
Yes.
What did that reveal?
Yeah, so in that we had run a local ultrasound with AV Doppler.
Okay.
So arteriovenous Doppler, the AV fistula was patent and there was no presence of any thrombus, but they were telling about a localized collection above the site of the AV fistula, so suggestive of an infection.
Understood.
And after following which, following the nephrology orders, we had moved on to the dialysis because patient had dialysis due day.
Okay.
So we initiated dialysis with heparin. And following after half an hour post dialysis, like during the dialysis time, there was presence of a sudden spurting of blood from the fistula site. It lasted, which within just during that starting itself, we applied sudden pressure across the distal site, distillate, using our hand pressure. Following which, we also applied a tourniquet around the distal site, and we also applied a proximal pressure by inflating the BP cuff.
BP cuff.
Yeah.
Okay.
So then we had earlier arranged blood for this patient. So we also checked the vitals of the patient at that time. The vitals wise, the patient had a heart rate of 120 beats per minute and also a BP of 130/110 millimeters of mercury, and a saturation of 96% in room air. And we had again done like following the blood loss, we had contained that blood loss, like the blood loss had resolved a bit.
Before applying the tourniquets, you gave direct pressure as well, I hope, right?
Yeah, direct pressure was initially given, but it was not subsiding.
All right. So that's why you proceeded
with the distal and proximal we had applied pressure. Then it had reduced a bit. Then then it's gradually subsided, but we took again point of care. We again repeated the CPC-CRP, which showed a mild HB drop from like of 1 gram. HB initially was 10.8, which dropped to a 6.8. So following which, we immediately called the vascular surgeon. So vascular surgeon also, they had come, and the patient blood was also arranged. One unit PRBC was also arranged, and the patient was on heparin. So we initially immediately started on heparin reversal agent of protamine sulfate also. Protamine sulfate was in a dose of 1 to 1.5 mg per 100 unit of heparin administered is the dose. So usually in case of dialysis, we give up to 1,000 units of heparin is usually given during dialysis. So we had given heparin of 10 mg. Protamine sulfate of 10 mg was given for this patient. And then also we had given for this patient injection Tranexa, 1 gram we had given IV over 8 minutes. Then following which also we had given him her desmopressin. So injection desmopressin of 0.3 to 0.4 microgram per kg. So we had given for her, she weighed around 60 kg. So we gave her around 1.8. So 18 mg was given, mcg. So this was given, and the patient was shifted to the OT immediately following the event.
All right.
Yeah.
So what are the take-home messages from this? So when we talk about infection in case of especially CKD patients, are there any difference between how a normal patient would present to the ER and how CKD patients with sepsis or an infection would present to the ER? In our case, it was slightly different. She is presented with classical symptoms.
Yes.
But in general, they would not present with this pain, tenderness and swelling. Yes. In general, they would present with full-blown fever, hypotension and tachycardia and all that. That's how they normally present. Yes. But in our case, it was slightly different. Yes. They presented with your usual rubor, calor, dolor and all that.
Yes.
Another thing, when it comes to infections in CKD patients, right? Why do infections, really flare high in case of CKD rather than the normal population?
Most CKD patients might be underlyingly diabetic.
Exactly.
So they will be usually having an immunocompromised status. So they have an increased propensity to get
develop infections. Very true. Very true. So here in our case, we had a case of AV fistula bleed/infection.
Yes.
Right?
Yes.
But the infection was mostly subcutaneous.
Yes.
So when we talk about arteriovenous fistula, let's talk about all the access that we have in case of hemodialysis. When we do CKD hemodialysis, what are the normal access that we have for dialyzing the patient?
The usual dialysis access involves the AV fistulas. So mainly it will involve the left radiocephalic. Radiocephalic AV fistula is involved. Then the another access is usually the like IGC. Like intravenous, the jugular, internal jugular.
Okay, you're talking about dialysis catheters.
Dialysis catheters.
So there is fistulas,
Yes,
catheters, and in some patients, what we note is that the fistulas, to make the fistulas, of course, there might be these issues, incompetent veins or arteries.
Yes.
In those patients, what do we generally use? We use grafts.
Grafts.
Yeah. So some commonly used grafts include your bovine carotid artery, that is an age-old technique. Then you have polytetraurethrofluorine grafts.
Yes.
And then some autologous veins can also be used as grafts. Now, one thing that we need to distinguish between these grafts and your normal fistula is that the complication rates in grafts will be more than your normal fistulas.
Yes.
Okay, we should remember that.
Yes.
So when we talk about fistulas, because we have a fistula patient here, can you talk a little bit of the anatomy so that we know why we are applying the proximal distal pressure and all that?
Yes. So usually there will be the presence of the radial artery and the ulnar artery. So that is basically involves the distal.
In our patient, which one did we have?
We had a radiocephalic. Yeah.
Okay, all right. So basically we have your brachial artery starting from the axillary artery, which moves down to the through the medial aspect, and it would move to the antecubital fossa, where it would give two branches, right?
Yes.
One is the radial artery, the other one is the ulnar artery. Radial artery, of course, moves lateral to the forearm. Ulnar artery goes medial. The radial artery would eventually anastomose with the ulnar artery, forming the deep palmar arch in the hand.
Yes.
So that is radial artery, and the brachial artery and the ulnar artery. Then you have the venous axis, of course, venous side, of course. So venous side, it would start from here, right? So you have your cephalic and your basilic. So cephalic would go laterally. It would go lateral, run lateral, and it would go anterolateral into the deltopectoral groove before inserting to the axillary vein. And then that is a superficial cephalic, while basilic is medial and it's a deep part. So it would go medial, and then it would go posteromedial in the arm, and it would first enter the brachial vein, and then eventually to the axillary vein. So primarily the fistulas in common, they do it radiocephalic, and then there is brachiocephalic, and transposition of basilic brachial. Okay, these are the three grafts that we normally do. Most common being radiocephalic, or it can be the brachiocephalic. Right. So in this case, it was radiocephalic. Right. So what are the common complications associated with the AV fistula?
Yes, usually the AV fistulas usually can have there's a propensity of high grade of infection. There is always a chance of infection with a localized collection along the site of the abscess. So and that's there's a high propensity. Another is usually there will be the presence of a venous hypertension. Hypertension and causing a venous stenosis. So the AV fistula can get blocked. So AV fistula blockade usually by a thrombus or a venous stenosis.
Okay, it can be either stenosis or thrombus.
Right. So these are the.
So how do they present to the ER? Like clinically, how can you find out whether they have a stenosis or a thrombus?
Yeah, usually on like our inspection, the patient will having a discoloration of the distal part of the hand. There will be presence of the vascularity will be reduced. So there will be increased the discoloration. Along with that, on palpation, there will be loss of bruit. So that's how we.
How do we manage such patients as in general?
In general, initially, but
vascular surgery should definitely be involved. And you can post the patient for a thrombectomy, or infiltration of alteplase can be done with, of course, the vascular surgery on the team with you.
Yes.
Now, the next thing that we have is infection that we talked about. Yes. So, if the patient, for example, had a dialysis catheter in situ, right, and the patient has developed an infection right now, how do we know that it is a catheter-related infection, How would we know that it's a catheter-related infection? So basically, you send the culture of both the catheter and the peripheral blood. So if there is a 4-fold rise in colony count of the catheter site blood that we have sent, that means it's mostly catheter-related infection. So in catheter-related infections, you normally start with vancomycin and gentamicin.
Okay.
Vancomycin, in general, we start. Why? Because in suspicion for MRSA, and at the same time we start gentamicin if you are suspecting gram-negative organisms as well. All right. This is again the infection in CKD patients should be treated very with high alert, because the chances of them going to full-blown sepsis is again very high. Right. Then what is the other complication? Of course, what we face today is, that day is bleeding. So bleeding approach mainly is our age-old technique of providing direct pressure for about 5 to 10 minutes. But again, for this patient, we had applied direct pressure for a long time, but still it was not being completely successful. Hence, we decided to go ahead with the proximal and distal pressure application, which obviously control the bleeding. Other than that, there is something known as gel form, which can be soaked in reconstituted thrombin and applied at the same area wherever the bleeding is happening. So you can increase the thrombin formation and the clot will be formed and the bleeding can stop. That is one way of doing it, but it depends on the institution again. Like if you're in a primary center, we'll have to proceed with our normal things. And then when this is happening, of course, you need to get vascular surgery in our team and inform them immediately. Yes. The other thing, as you told, one of the common causes for bleeding would be anticoagulation-induced bleeding. Yes. Like because heparin is given in these patients. The other reasons for bleeding include trauma, and also it can be any rupture as well of the as you rightly said. So we gave protamine sulfate. Protamine sulfate, again, could you repeat the dosing for protamine sulfate?
Protamine sulfate is usually given at a dose of 1 to 1.5 mg per 100 units of heparin.
So it's normally 0.01 mg per unit. So normally for dialysis, we give around 1000 to 2000. So if you don't know the dosing, if the patient is dialyzing outside elsewhere and the patient is presenting to us, we can give around 10 to 20 mg of protamine sulfate is what the regular this thing says. And another thing that we can do is when you apply the pressure, if at all vascular surgery is not available at this point, the one thing that we can do is a figure of 8 suture application. But one of the thing before doing that is that once you apply the tourniquet, you should again see the bleed, because one of the reasons why the patient can have a bleed is because if there is an ulceration over the fistula. Okay. If it's ulcerated and if you apply a figure of 8 suture, the ulcer itself can get removed and you might cause a complete rupture of the vessel, which would aggravate all the issues more. So if you apply a figure of 8 suture, if in case you're good with your surgical skills, which obviously we should be, we'll have to use a non-cutting 5-O-proline. Because 5-O-proline, non-cutting because less trauma, and 5-O-proline why? Because the needle is going to be very thin and the needle, the suture material is going to be bigger than the needle. So once you create a trauma, it is going to be completely occluded by the thread itself. Okay. So that is something that you can do. Is there anything else, along with this we should do in case of bleeding?
Okay. Blood arrangement.
Blood should be definitely arranged, and I guess tranexamic acid should be given after probably consulting with the vascular surgery themselves. Some other complications of fistula, what are the other?
Usually they can be present of an aneurysm. So aneurysm can be a true aneurysm or a pseudo aneurysm. So true aneurysm means the dilated, all layers of the vessels are involved. So that's usually the dilatation will be more than 1.5 times the typical diameter of the vessel. Okay. And pseudo aneurysm is usually the disruption of the vessel wall due to the collection of the blood. So that creates a false lumen. So that's how
mostly pseudo aneurysms will be subcutaneous bleed, but the aneurysmal ruptures can be life-threatening. That will be very serious. Any other complications in AV fistula?
Yeah, so AV fistula initially during the application, patient can have a median nerve dysfunction.
Okay.
Median nerve injuries can occur. These are the usual complications.
Something known as Steele syndrome in the AV fistula patients, just to brush it off. basically when the fistula is created, because this is the pathway of ease resistance. There's no resistance at all when a fistula is created. So what happens is distal to the fistula, the circulation can get impeded at times because the blood doesn't flow there because there's a pathway of least resistance here, right? So sometimes the patient can present with pallor, pulseless, and cold extremities. So you should suspect Steele syndrome at times. The other thing is some high output cardiac failure can happen. So high output cardiac failure, why? Because that's again diagnosis if more than 20% of the cardiac output is going through the through the fistula itself.
Yeah.
So that will be proved only by Doppler. Clinically you can do it, but then it's a test which it's called a Brandman test, Brandman sign. Basically, once you occlude it, the patient is in high output failure, so the patient will have tachycardia, hyperdynamic kind of failure.
Yeah.
So when you occlude it, there will be immediately you can see on the monitor that the pulse will come down and the BP will get better. The patient symptomatically will feel better. That is one way of doing it, but then of course you're occluding it, so you couldn't do it for a long time. But when you do a Doppler, if there is more than 1 to 1.5 liter per minute flow through the fistula, that is indicative of this thing. So overall, we had a patient who presented, CKD patient who presented with a AV fistula and site infection, and the patient bled during the dialysis, most probably because of anticoagulation.
Yes.
We applied direct pressure, but it was not subsiding the bleed. We applied tourniquet, and then we got a vascular surgery consult. We gave protamine sulfate and controlled the bleed, but then the bleed was good enough to cause severe hemorrhage, and we had to transfuse on-time blood, and the patient was operated later, and that's how we managed the case, I guess, right?